Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to our 5th Annual National General Medical Oncology Summit. We're thrilled to be back here again working with the Florida cancer specialists. We had a great program last night on lymphoma, and we have a lot of stuff to cover today and tomorrow. We are really looking forward to this. We have some fantastic faculty who've come here to Florida, almost 40 investigators, as well as a bunch of Florida cancer specialists are going to join me here on the stage to co-moderate and ask questions, as we always like to do, of the investigators. So we're really grateful for their participation. As always, we will be discussing the use of unapproved agents and regimens, so check out the package inserts for more information. All right, so we're going to start out talking about one of the most interesting areas, I think, in oncology. A lot going on this year, chronic lymphocytic leukemia. We have Dr. John Allan from the Weill Cornell Medicine in New York City, as well as Dr. Adam Kittai, also from New York City in the Perlmutter Cancer Center, and Dr. Susmitha Puri from the Florida Cancer Specialist in Inverness and Lacana, Florida. We're going to start out talking about management of newly diagnosed disease, but just want to take a breath first, faculty, and say that all weekend, we're going to be asking the faculty at the beginning of these meetings a question that I actually asked ChatGPT before we started this weekend. I'll compare your notes to what ChatGPT has to say. Here's the question that I asked, which is, what do you think was the best paper of the year, the most impactful presentation of data, and where do you see things heading in CLL in general? So I'll start out with you, Adam. Any thoughts about the big paper of the year, papers of the year, of the past year, let's say?
Sure. I would have to go with the CLL-17 study. And the reason why I would pick that is while I would say that the results were what I would have expected and guessed from the study, I had a lot of presentations for CLL that constantly said our novel therapies have never been compared to each other, so we don't know which one works better or if they're the same. But now we actually have data to say that continuous therapy with ibrutinib compared to VO, compared to IV, the efficacy is overlapping. And so what I like about the data too is that we can really decide how to treat our patients based off a patient preference given that data, really tailored down to what the patient's hoping for, knowing that whatever we pick, the patient's going to do really well.
So actually, John, I had previously asked ChatGPT, what do you think is the most important paper of all of oncology, the top 10 papers, and they brought up CLL-17, also Amplify. Any thoughts about where things are heading with CLL? It kind of seems like we're moving more and more towards time-limited therapy, MRD assessment.
Yeah, I agree with the comments. The Amplify study was, very important because it allowed the approval of our first all-oral fixed-duration approach, and I do think the vast majority of our patients are wanting time-limited treatments, and these data sets, with longer-term follow-up, are really going to highlight subgroups of patients that might do better with a certain approach, and having all of these different approaches available is really going to help us, tailor the treatment to the patient and really personalize it in CLL.
So, Susmitha, we're looking forward to hear the questions that you have. I was asking you, when was the last time you started somebody in treatment for CLL? You told me you had 2 patients, and they both chose time-limited therapy. What therapy are they on? How old are they? Any questions you want to ask the faculty about this kind of strategy?
Yes, thank you, Neil. So I have 2 patients who I treated with venetoclax and obinutuzumab, and both of them are in their mid-60s, and they just come towards the end of the therapy. Both of them chose the time-limited therapy, but I think in the community oncology practice, there are still many patients, who prefer the single-agent therapy for flexibility and travel plans, and also toxicity and less time in the clinic. So how do you approach the patient when you offer them single-agent therapy versus the doublet therapy, first thing? And I also wanted to ask you if there is any role of minimal residual disease in single-agent therapy.
And you mentioned that you already had an MRD assay because one of these patients just finished and it was negative. John, if it were positive, would it change what you do?
Yeah, at this time, all of the data that we have is really just based on fixed duration and not really modifying our therapy based on an MRD result. It's prognostic. It's nice to know where you stand, to educate your patient, to set expectations for yourself on when you might have to deal with disease again. Fortunately, with VenG, the vast majority of patients are MRD negative at the end of treatment. They will do well, but while there is data to support potential MRD-guided approaches, extending therapy, things like that, the kind of standard talking point and kind of how we roll it out to larger groups of practitioners is it is really built on a true fixed duration, 1 year of therapy, and kind of just letting it be and just following the patient closer if they are MRD positive at the end of that treatment.
So, Adam, these people, I think, seemed like they were treated just about the time Amplify was getting presented, so maybe that wasn't an option. But I'm curious if these same two people presented today, and I don't know what your thoughts are, in terms of if you had offered instead of obinutuzumab, acalabrutinib, do you think the patient would have preferred doing that? And people say, well, for people who would prefer all oral, who wouldn't prefer it? Any sense about whether you would have brought up Amplify if they were presenting today as Usmitha?
Yes, definitely. I would have brought that discussion up with the patient. But my concern is I do see a little bit more infection risk adding venetoclax. And I wanted to, if I put them on triple therapy, how are they going to tolerate it? So tolerability is a question. And I would like to ask the experts, what their experience has been. And the second thing is when I do venetoclax, the question I always have is, should I put them on prophylactic antibiotics? And is that common practice?
And also, right now, Adam, are you generally offering Amplify or acalabrutinib venetoclax to your patients? Any concerns about infections?
Yeah, I do offer Amplify to my patients, acalabrutinib plus venetoclax. And the reason that is that it's all oral, time-limited therapy given for 14 cycles. Other reasons that I think it's really beneficial for patients is that with the 2 cycles of acalabrutinib lead-in, it really mitigates the risk of tumor lysis syndrome when you add on the venetoclax. Last but not least, we've all seen those patients who get the obinutuzumab and have significant infusion reactions and tumor lysis syndrome just from the obinutuzumab. So the acalabrutinib plus venetoclax really helps mitigate those toxicities that we're concerned about. To your question about triplet therapy, the answer is it's complicated. Unfortunately, there were now 2 trials that have shown higher risk of death with the triplet therapy. So there was the Alliance study that was ibrutinib, venetoclax, obinutuzumab versus ibrutinib plus obinutuzumab. This was done with older patients and also done during COVID-19, and patients in the triplet arm had higher risk of death from COVID-19. And we saw similar results in the Amplify study where patients who got the acalabrutinib, venetoclax plus obinutuzumab also had higher risk of death and ultimately led the FDA not to approve the triplet regimen and just approve the acalabrutinib plus venetoclax. So a scenario where I would potentially use the triplet regimen is actually in patients who have high-risk disease who are younger. So there was the Matt David study that used MRD-directed acalabrutinib, venetoclax plus obinutuzumab, and it seemed to mitigate the risk of TP53 aberrations, which is something that I would potentially offer to my patients who are interested in time-limited therapy, who are younger, who have high-risk disease, and who really want to come off therapy.
That's a great point. Yeah, and we're going to take a look at the data. It's difficult to look at the data that occurred during the active COVID regimen because you're given anti-CD20 and that's an issue. There are a lot of COVID deaths in both arms, I think, as well. So it's kind of hard to interpret that. All right, John, let's take a look at some of the data.
Great. So I was set out to talk about some of the frontline approaches that we're using and kind of summarizing that space. So that's what we're going to be talking about. Here are my disclosures. So we are really thinking about these concepts that we just spoke about, treat to progression, monotherapy BTK approaches where you are, that's our tried and true standard since basically 2016, versus now our fixed duration or MRD-guided approaches, which MRD-guided approaches technically are in our NCCN guidelines. And within our fixed duration, we have VenG or our acalabrutinib venetoclax approaches as FDA approved. Obviously, they've got pros and cons, and they're listed here, convenience and limited, clinic visits, but you're on treatment for a long time. There's, toxicities that we're going to to have to deal with. And on the other side, while fixed duration is great, you get off treatment, there is this time-intensive component where you have to really invest 2 to 3 months of your first time on the treatment to committing yourself to doctor's visits, follow-up, monitoring, lab visits, etc. But you get off of treatment, and we're seeing that with long-term data, you can be off treatment for a very long time, and that frees patients up from toxicities and other issues. So here's a summary of all the monotherapy BTK inhibitor data. This is technically old data. These are 7- and 10-year-old studies that has been now updated here. So Resonate-2 put ibrutinib on the map in front line against chlorambucil. The follow-up is done. It followed for a decade of patients, and the median progression-free survival was finally met at 9 years. So really, really impressive when you talk about oncology median PFSs. And so this is dramatically improved over what we used to be able to get out of chemoimmunotherapy, and it changed and revolutionized the world in B-cell malignancy management. Overall survival at 10 years is about 70%, and that is the threshold that all other BTK inhibitors need to meet or exceed, and other fixed duration approaches kind of need to meet or exceed in terms of being relevant in management. Resonate excluded p53 disrupted patients, but we have 2 studies that show how these patients are doing. And as a reminder, with FCR and BR, median overall survival was 3 years, and median PFS was about a year with chemotherapy. Here, we see median PFS a little shorter than those patients without deletion 17p at around 7 years, but the overall survival is what is important, is basically it is the same as those patients without deletion 17p. So we've somewhat overcome this high-risk feature and put all patients, even with this very high-risk feature, basically on the same playing field. They may still progress a little bit sooner. They still are at risk for developing resistance to these drugs, but we've got other agents to rescue them, and 10 years later, still 70%, close to 70% of these patients are still alive and looking good. Now we have 6-year data with both acalabrutinib and zanubrutinib, and you can see tracking historically well along the lines of where Resonate-2 was. Now, obviously, obinutuzumab is added in with the acalabrutinib, and it may add some benefit, but nonetheless, it does add some toxicity in terms of infections and things along those lines. We've moved to our second-generation drugs for the cardiovascular risks and a little bit better tolerability. We have our fixed-duration standard, which is Ven-Oben. Here, the median PFS for all patients is about 6 years. This has not been updated for a few years, but I think we'll be seeing some updates soon. What we've learned, though, is that those patients with mutated IGHV can do very, very well, and with Ven-G. Even the unmutated patients can do well, but they can do a little bit better. And if you're MRD negative, you can clearly outperform those patients who have MRD positive disease at the end of treatment, but those patients can still do also very well. We know deletion 17p, unmutated IGHV, and bulky disease put patients at risk for inferior progression-free survival with a Ven-G comparatively to those patients without it. But again, we're still talking many, many years for the vast majority of these patients. And when you look at overall survival, complex karyotype has come out as being a potential risk factor at having inferior overall survival compared to those without when treated with Ven-G. So maybe these higher-risk patients, we need to still figure them out. Is continuous therapy maybe the best approach for them? We don't know that from this study. Obviously, patients didn't continue on therapy, but we are seeing risk factors that might start to differentiate those patients getting a fixed duration approach. Now we're getting into the new era where we're at, where in the US we have now BTK, BCL2 combinations. This schema kind of summarizes all the potential synergies and the additive mechanistic effects of the various drugs. The BTK inhibitor stops proliferation, spills the lymphocytes out of the lymph node niche into the peripheral blood, where venetoclax can really act and kill these cells. And so these are all the various synergies that we see with this dual BTK, BCL2 inhibition. This leads us to the Amplify study, which is A plus V versus AVO versus chemoimmunotherapy. It was about 50-50 FCR-BR in that group. Deletion 17p patients were excluded from this study. As a reminder, AV is a cycle of A, then you bring in the Oben with A in the triplet arm, and then you bring in the venetoclax at that cycle 3. So there's 1 month of BTK, 1 month of BTK Oben, and then that third month, all 3 of the drugs, and otherwise it's 2 months of acalabrutinib bringing in with venetoclax going forward for 14 cycles total, 1 year of combination therapy. Here, what we learned is that AV, which was this study was powered to look at AV versus FCR-BR in terms of how it was powered and statistical significance at the 3-year time point, and AV met that primary endpoint of superior progression-free survival. We see here 76.5% versus 66.5%, so a 10% improvement. But you look at that AVO arm, and you're like, hey, well, AVO did even better than AV, and it's hard to argue that. And the OBIN is a very powerful drug. It's a very powerful molecule, and it can absolutely enhance responses, deepen MRD negativity at the cost of some toxicity and logistic issues. And so where to place it, how to place it, isn't fully idealized yet. And obviously, Dr. Kittai spoke about where he might use it, and I agree with a lot of those comments. But there is an advantage there. You just need to be comfortable using it, understand it. As you can see, the MRD rate it increases when you add in that antibody, and that ultimately can potentially translate into the improved progression-free survival that we are seeing. You can see, though, that on the left side, the patients who seem to benefit most from the addition of the obinutuzumab were those patients with higher risk disease, the unmutated IGHV. On the right side, those lower risk patients, we don't probably need to really throw everything at them. They're going to do well kind of no matter what we give, and we can start to ease some of the exposures and maximal therapy on these patients because we're probably not doing a whole lot for them and exposing them to logistics and toxicities and things that they're not going to get much benefit for. So again, what Dr. Kittai was saying, restricting it to maybe higher risk disease if you're considering it, it's in our NCCN guidelines, but at the end of the day, the AV patients can still do very well with unmutated IGHV. Here's the toxicity. It's a busy slide, but the few points to highlight here is that with acalabrutinib, very low rates of cardiovascular toxicities. And we see AV have some neutropenia, and the O adds to the neutropenia, so be aware of that. But it's not something that can't be managed with growth factor and close monitoring, and it is something that can improve with time as you clear out the CLL, et cetera. When you add in the O, it doesn't add a lot of toxicity cardiovascular-wise or any of these things aside from the cytopenias and infections. You can see the infection rates, while any grade infections are similar, you see higher grade 3-4 toxicities. And then when you look at the very bottom there, the COVID-19 deaths, this is what we said, this was in the worst part of COVID being done, and we see nearly double the COVID deaths in the AVO arm. So this is a signal that we continue to see with antibody usage, and we need to be very careful when you're using it. I do wonder if this study was done now in this era of COVID, if this would be similar results, but nonetheless, it is something very serious we need to take seriously as we look towards using these regimens.
So before we continue, just Adam, I'm curious, how do you decide between the Amplify strategy using Acala with venetoclax versus the older strategy of obinutuzumab venetoclax?
Yeah, so my personal opinion is that the combination of acalabrutinib plus venetoclax is easy to deploy. It's all oral. I get to avoid the obinutuzumab, so I am generally favoring it. That being said, the data for unmutated IGHV with VO looks a little bit better, but we'll have actual data that compares VO to AV coming out soon in the MAGIC study, so we'll be able to actually see if the obinutuzumab adds enough to counteract the ease of doing all oral therapy with AV at this point.
So, John, Susmitha says she hasn't used the Amplify strategy yet. Any advice to her about how to prepare a patient and her staff for that strategy?
Yeah, I think it's nice because you're used to using BTK inhibitors, and we get to start with that for 2 months. And so patients can adjust to and it's a concept and a discussion that can continue over the first month, et cetera, as you bring them back, continuing to reiterate when the venetoclax is going to come in, educating them about toxicities. And so, whereas Obin and Ven, everything kind of starts right then, and you got to be ready to go. We start with the BTK inhibitor. You've got 2 cycles before you're really bringing in the venetoclax. It helps ease things in. Patients start to feel better. They start getting comfortable. But it's still something you want to start to have the conversation before you start the regimen, letting them know that the venetoclax will be coming. But it's easier to get going. We're comfortable with these drugs, and it buys us some time before the more logistical, complicated part of the regimen comes into play.
Any questions, Susmitha?
So if there is a patient who is progressing on acalabrutinib, do you think there is any benefit of adding venetoclax? I know that's not how the study has been done, but just curious.
Adam?
We actually have a trial that will be presented at EHA where we looked at patients who were being treated with BTK inhibitor and were developing BTK mutations and then adding in the venetoclax later. So a little bit different than overt progression, but these patients were likely to progress within a year. And the data looks pretty good that you can add in venetoclax in that state. To be honest, though, it's not standard of care. And so how I usually manage somebody who's progressing on a BTK inhibitor, and I want to put them on venetoclax, I will overlap it for about a month or two while I get the venetoclax ramped up, and I'll do it with an anti-CD20 monoclonal antibody. So I do think that's a venue that we can consider because there is some evidence of synergism between the venetoclax and the BTK inhibitors that may be useful in somebody who's progressing, but I typically would change mechanism at that point.
So, John, any thoughts on that? I mean, pirtobrutinib would also be a possibility.
Yeah, I think obviously, I wouldn't look at it as AV would then be that regimen going forward, their resistance to the BTK inhibitor, but, pirtobrutinib is a drug that's approved in that space. There is some combination data there. Obviously, that's not on label, but we do these things in practice. And in general, I agree with Dr. Kittai. I would either get the VEN on board, start getting them controlled, but probably release them from the BTK inhibitor, bring in the antibody, and then use that VEN-R or VEN-O approach as truly the therapy going forward.
So we're going to move on now and get into other agents, particularly other BTK inhibitors, zanubrutinib, pirtobrutinib, also another BCL2 inhibitor coming along, not approved yet. So in sonrotoclax, I'm curious about these other approaches. How about Sequoia?
Yeah, so Sequoia is looking at zanubrutinib and venetoclax. This is in the NCCN guidelines as an MRD-guided approach, and so it's a little bit more of a complicated scenario here rather than just a true fixed duration. But nonetheless, this is a big phase 2 study, at least the portion with the zanubrutinib venetoclax, initially looking at only deletion 17p patients and then all comers. So now we've got about 100 plus patients treated, and this is the study schema. They get zanubrutinib for 2 years in combination with the venetoclax. If you're MRD negative and could met the criteria to stop, you stop the VEN at the 1 year time. If you weren't MRD negative, you continued on the doublet therapy for an additional year, at which point you rechecked. If you're MRD negative, you can then stop. Those patients who did not get MRD negative took their venetoclax off at 2 years, but then continued on zanubrutinib maintenance, basically. So that's how this study was done. You can see with any venetoclax-based approach, we have about CR rates of about 50%. And on the right side, while at 1 year, or that 15 cycles, we don't really see super high rates of MRD negativity. It's similar to what we saw with A plus V, about 30% or so of patients get MRD negative after 1 year. We do see that increase to about 60% with that additional second year, and we can get patients off of therapy. As you can see, very few, about 10%, were able to actually meet the criteria to stop the VEN at the 1 year. But by the 2 years, we're now up to about 40% or so of patients, 30 to 40%. I think we could still do better, honestly, because that's 60% of patients that then maintained on zanubrutinib, and the whole point of it is to try to get patients off. So nonetheless, though, it's very effective. Patients can get very deep remissions, and clearly those patients who stopped maintain their response in MRD negativity. Here are the progression-free survival outlooks, and it looks great. These are very flat lines. They're close to 90% at the 3-year time points, and it just shows you depth of treatment. And again, these are dirty lines because some people are on treatment, some aren't, and so not everybody on the line is being treated uniformly, but nonetheless, very good outcomes and very safe regimen and overcoming some of these high-risk features like IGHV mutational status. Again, a very safe regimen. We're using zanubrutinib, a second-generation drug with venetoclax. We still see issues with hematologic toxicities. Again, it can be managed. It's not something that is really preventing a lot of patients from being able to continue on. Infections and things like that, BTK class effects are here. You need to monitor for these things, but by no means is it a regimen that's difficult necessarily to use.
So again, before we go on, Adam, of course, people are very interested in time-limited therapy, but there are other people who want just single-agent BTK. As you mentioned, sometimes a high-risk L17P, you would consider that as well. The question's been out there for a while, which BTK? Mainly between Zanu and Acala, although now Pirto is starting to come into the discussion. I'm curious, Susmitha, when you use single-agent BTK, what do you generally use?
I use zanubrutinib.
Right, I hear a lot of people saying that. Curious how you make that decision, and any thoughts of whether at some point pirtobrutinib is going to be part of the equation?
Yeah, those are great questions. So we don't have any head-to-head data of acalabrutinib versus zanubrutinib. We just have some make analyses. To be honest, how I think of them is I think that they're pretty similar. And I actually tend to use more acalabrutinib. And the reason that is that I had taken over a practice of somebody who had led all the acalabrutinib trials back in the day and just got really used to the drug. And so that's why I tend to use the acalabrutinib. I've started using more zanubrutinib in certain circumstances that are just very nuancy. There's some good data for zanubrutinib and Richter's transformation. So patients with like a Notch1, CDKN2B, trisomy 12, I sometimes will reach for zanubrutinib, or if they're Ki67 on the pathology is a little bit higher than my liking, I might pick up zanubrutinib, but I tend to favor acalabrutinib just for use and how much I've used it. Now, the question about pirtobrutinib is a great one. I'll show you some of the data in my slide deck, but pirtobrutinib is now being studied in the front line, and it actually released data of pirtobrutinib versus BR and pirtobrutinib versus ibrutinib. And really, the really most interesting data is the pirtobrutinib versus ibrutinib data, and it needs more time to play out, but it looks like the PFS benefit is there with pirtobrutinib versus ibrutinib. So we'll see how that plays out over time. But the concern with pirtobrutinib is that you might develop a resistance mutation that might confer resistance to both the covalent and the non-covalent. So we need more time before we can start using pirtobrutinib in the front line. But certainly it looks like a safe and effective drug for sure.
So, John, the cool thing about general medical oncology is we get to see different strategies that are very similar in different tumor types. You're really going to see that this weekend. Time-limited therapy. We're going to, think about prostate cancer. I'd call that some of what we do there, time-limited therapy. But getting back to this issue, and then a lot of time, of course, another huge general issue in oncology is choosing between different agents in the same class. A lot of times you don't have direct comparisons. And getting back to the basic question of acala versus zanu, we want to kind of think that these are all the same, but there are differences pharmacologically, and there are some data that suggest maybe zanubrutinib actually has a PFS advantage compared to ibrutinib. Maybe an efficacy advantage theoretically over acala. Any thoughts about that thinking?
Yeah, so the pharmacokinetics are different between the drugs, and zanubrutinib has a unique feature that it allows the drug to stay above the IC50 throughout the entire dosing interval, and that's unique to zanubrutinib as compared to ibrutinib or acala. Pirto, though, also has that same feature. Actually has the most selective and the highest IC90. It actually is above the IC90 throughout the entire dosing interval. So Dr. Kittai was speaking about high Ki67, because the only way to reestablish B-cell receptor signaling with these drugs, because they're covalently bound, is to resynthesize drug. So if you have high proliferative disease, you might be resynthesizing BTK, and maybe there's some value in having drug around that is still able to inhibit any newly synthesized BTK. So those are some of the hypotheses around why maybe there's some subtle efficacy differences, particularly against ibrutinib. Again, no head-to-head data against acalabrutinib, and any of the cross-study comparisons that have been done with these MIACs show that efficacy-wise between these drugs are basically the same, and I agree with that. I don't really view any of these drugs too differently in terms of efficacy or even in safety. We still are dealing with all the BTK class effects. Zanubrutinib is unique in that it has some flexibility in the dosing. You can go once a day or twice a day. That's one of the major features that I like to use the drug with, is the once a day option. And now they, instead of 4 capsules, it's now down to tabs, and it's a little bit the pill burden is a little bit less and easier to handle. So these are important factors to keep in mind. But again, it's physician preference and your comfort levels with these drugs and the toxicities. But ultimately, you have to be aware of all of the BTK class effects, and essentially expect the same outcomes with any of the agents that you use.
So before you get to CLL17, one more question for Adam, getting back to pirtobrutinib. Pirtobrutinib has the reputation, so to speak, of being the best tolerated BTK. But a lot of the trials in relapse disease, these patients already had BTK, so they may be the ones who had problems, got screened out. What do we know about the tolerability of pirtobrutinib in the first line? Is it also better indirectly?
Yeah, so all we have is pirtobrutinib versus ibrutinib right now, and pirtobrutinib's AFib rate is in the single digits compared to 13% for ibrutinib. So it certainly looks like it might hold in the front line, but once again, it's ibrutinib, it's not the second generation BTK inhibitors.
Well, I mean, also, if you think about it in terms of ibrutinib versus, let's just keep going, actually. Let's go to CLL17 before we get too far behind.
Yeah.
I start getting crazy with my questions.
Yeah, no, this is great. This is great. We love talking about this stuff. So, to put this all together, we have not had that perfect study in CLL, and finally we have gotten close to the perfect study, and I argue it's not the perfect study because it doesn't have that triplet arm to compare to all of our modern regimens in it. But nonetheless, we finally got rid of the chemotherapy arm that we ignore always in all of these studies that we're talking about. And the CLL study, 17 study, which was a behemoth effort of the German CLL study group, 1,000 patients accrued within a year, a little over a year and a half, which is a really impressive effort. Looking at ibrutinib monotherapy continuous versus venetoclax-obin, the standard 1 year of therapy, against venetoclax-ibrutinib as the standard basically 1 year of therapy with the 3 cycles lead-in of ibrutinib. And this is now 3 years of follow-up. Primary endpoint was progression-free survival. And so here we can see deletion 17p patients were included. Any patient could enroll on this study. Essentially, it was a little, it was, I think, in the mid-60s was the median age, and so kind of all comers, it went up into the high 80s. You can see the venetoclax-based approaches, CR rates around 50%. Ibrutinib, we know it doesn't get CRs, but who cares, because we know that it's going to maintain your disease for a long, long period of time and actually deepens over time. On the right side, you see MRD negativity. Again, the obin added to the venetoclax, showing the signal that you can deepen the response, get MRD negative at higher rates than with ibrutinib and venetoclax, with about 50% of patients getting there with ibrutinib and venetoclax. Ibrutinib doesn't get there, and so keep this in mind as we see the data in terms of progression-free survival, because right now at 3 years, there is no difference between these arms. And so you can say, well, hey, that means continuous therapy BTK, it hasn't been beaten. I think the other way to look at that is that this establishes fixed duration approaches as a completely reasonable option for your patients, showing that you're not going to do any harm or they're not at risk for an inferior survival. And that's kind of how I look at it. This study really put fixed duration approaches, I think, on the map because the outcomes are basically the same, at least at this 3-year time point. Overall survival, again, no difference. The obin had some infection deaths related to it, again, during some COVID periods of time. But I think that's going to equal out over time and probably not be too different. And so, as Dr. Kittai was saying, this opens us up to still putting the patient preferences as still the first ideal for us when we're choosing a treatment and discussing what makes sense for them, because any approach goes, and really, these outcomes are really, really impressive. When you get into the nitty-gritty details, these lines, I think, will start to separate with time. This is 3-year time point, only about 1.5 years off of therapy for the fixed duration approaches. Those patients with mutated IGHV, though, are looking very good with the Ven-Obin, though we see higher risk disease starting to separate out with fixed duration approaches, Ven-O or IV. On the right side, you see those patients with deletion 17p starting to have lower PFS rates at this 3-year time point. Again, their overall survival has not been shown to be detrimental, and so it's still an option for these patients. You just are going to have to deal with them sooner than you might otherwise. Safety looks pretty good across the board. Slightly higher hematologic toxicities with the obin and the venetoclax. Infection rates, any grade, are pretty good across the board. Maybe it's slightly higher grade 3-4 toxicities, again, with the obin added to it, but nonetheless, pretty comparable regimen across the board. And so A plus V is now approved as a second fixed duration option. Our guidelines do acknowledge our triplet approaches and response adapted approaches, so talk with colleagues if that's something you want to think about. Unmutated IGHV may have some benefit with the triplet. The mutated patients can do very well with any of these approaches, frankly, and currently CLL17 at 3 years of follow-up, no differences between the groups, and allows us to choose any of these options is completely appropriate for our patients.
So we want to talk about where things might be heading. And Adam, you're going to be talking about a new BCL2 inhibitor, sonrotoclax. And I'm curious, before you get into the data in terms of just sort of the ins and outs of using sonrotoclax compared to venetoclax, also curious what kind of issues Susmitha runs into in terms of using venetoclax, what kind of patients don't want to go through that type of procedure in terms of prevention of TLS. And before we get into efficacy, what about actually using sonrotoclax? I've heard that maybe the ramp-up's a little easier.
So the interesting thing about sonrotoclax is that there's been 3 different ramp-ups that have been studied so far. And so I know there's been work on getting that ramp-up to be easier, and we'll find out more about the ramp-up in probably the next year or two. The zanubrutinib sonrotoclax versus VO trial, the Celestial study, also should read out maybe in 2 years as well. It's fully accrued. So the ramp-up actually hasn't been solidified just yet. So I'm excited to see how the ramp-up does get solidified, and I'm hopeful that the lab monitoring around the ramp-up becomes easier compared to venetoclax. That being said, there's also studies being run with venetoclax to try to make that ramp-up easier as well.
Interesting. So, Steve Smith, how do you see people responding to the idea of getting venetoclax? There's a few more visits and blood drawing, et cetera. There are people who don't want to deal with that. How much of an issue is it for you?
I don't think it's an issue as long as we discuss the ramp up with them and we write it down. And we also have excellent pharmacy support, so they're always talking to them every week, trying to make sure that they're getting it right. I think the only issue for me is to get them from that to the 400 to the full dose. Sometimes that's a challenge. I see that the cytopenias are worse, the fatigue is worse when I'm trying to get them to that full dose, especially when I use it with the obinutuzumab. Is what I have noticed. And I would like to ask, do you offer any IVIG therapy in this setting? That's the one question that always I think about when I see these patients.
John?
Yeah, so around the cytopenias, aggressive growth factor use can help you get ramped up. Obviously, if they go agranulocytic or really severe deep grade 4, you should stop the drug and give some growth factor and let it recover, et cetera. But as you get disease cleared out, things will get easier as it goes forward. But the OBIN does cause some problems and things can drop. So you need to just monitor it. But you can push through it typically for the vast majority of patients. Regarding IVIG, yes, we use it. Typically, obviously, still the indication is a hypogammaglobulinemia, IgG, less than 500, with 2 or more infections over 6 months. That's the technical indication, or a severe infection anytime in a year with hypogammaglobulinemia. So I really do try to follow those indications because, again, it's another infusion. Sometimes you can do sub-Q or they can get it at home, but, it's not so subtle and it's got some logistics and some toxicities that you have to deal with. It can be expensive to the system and insurance and all these types of things. So you know it when you see it, when to deploy it, basically, and I make sure that we fit the criteria for it before I do it. So, but I don't blanket just give it for everybody on these antibodies.
So, Adam, before we get into your talk, a question from the audience, a 65-year-old patient who already has AFib on anticoagulation. I'll present the case later, but we were talking about AFib before in terms of pirtobrutinib, where, as you said, actually the risk of AFib is the same as BR, which makes you think maybe there isn't even a risk there. But what about the patient who already has AFib on anticoagulation? How do you think that through? Do you try to get them off the anticoagulation with a procedure or just treat?
Yeah, that's a great question. So first off, whenever I have a patient who I'm thinking about starting on a BTK inhibitor and they have underlying cardiac disease, I talk to my cardiologist very frequently. And so with atrial fibrillation, there's a very big difference between somebody who's just on, metoprolol with a Pixaban than somebody who's requiring a Watchman, who's got cardioverted, who, is on amiodarone. Like, those two differences are very, very different, right? So if you have somebody who's controlled with their atrial fibrillation just on a beta blocker, probably fine to go ahead and start a BTK inhibitor with close monitoring. I've also talked to the cardiologist about doing a dose reduction on the DOAC, going to 2.5 on the apixaban versus 5 twice a day. So that's something that you can talk to them about, and they may be willing to switch them around a little bit. But, as I said, the types of AFib, we tend to pocket into one type, but really the difficult to control is very different than the easy to control, and I think those are two very different scenarios.
All right, let's talk a little bit about non-covalent BTK inhibitors and also other strategies.
Great, thanks. Here are my disclosures. Here are our objectives for today. So let's talk about the non-covalent BTK inhibitors. So we have pirtobrutinib, and this is the only one approved. There's also nemtabrutinib, which is also being developed. And we talked a little bit about this earlier today in terms of pirtobrutinib's selectivity. So on the left, you have a kinome map. On the next slide, I'm going to show you the kinome maps for the current available second-generation BTK inhibitors and ibrutinib as compared to pirtobrutinib. But you can see that the pirtobrutinib is very selective for BTK with not many off-target effects. Those dots, those circles, are where the kinase hits on the kinome. Additionally, we had talked about the importance of IC50, and you can see that pirtobrutinib does maintain drug exposure above IC50 throughout the duration of the drug. And last but not least, for pirtobrutinib, it also does lead to this conformational change in BTK, which might make it more effective. And one thing to add here, too, is, and just to remember, is that the pirtobrutinib was specifically developed to overcome resistance mechanisms for patients on covalent BTK inhibitors. So first off, they bind differently. They're non-covalent versus covalent. And they also don't rely on the binding of the C481 binding loci, which is where the resistance mechanism typically occurs for our covalent BTK inhibitors. So here's the kinome maps that I had talked about. And you can see on the left that acalabrutinib and zanubrutinib are also pretty specific for BTK, and ibrutinib has a lot of red dots, right? So this is the hypothesis of why we see more toxicity with ibrutinib, because there's a lot more off-target effects for ibrutinib versus our second-generation BTK inhibitors. And while the same kinome map is not used for pirtobrutinib, it gives you some visualization to get an idea that it is pretty selective to BTK with not many off-target effects. So this is what I was talking about earlier, and I remember being in medical school and seeing these molecular structures and really not understanding what I'm looking at. But here I am presenting this molecular structure to you because I feel like it does actually do a pretty good job of getting your head wrapped around what we're talking about. So you'll see that these squiggle lines are all BTK, and the covalent BTK inhibitors bind to this pocket, and the green square highlights where it binds at C481. And now when you look at pirtobrutinib, the orange blob, you can see that it doesn't really touch the area of C41. So my point being is that it binds to a slightly different pocket within BTK that prevents, that allows it to work in patients who have that binding inhibition of C481S, which is the resistance mutation that we see with the covalent BTK inhibitors. To go over those mutations once again, the standard one for the covalent are C481S, but we do see these other mutations that do pop up, but these mutations typically pop up with the non-covalent BTK inhibitors, and those include T474I, L528W, which really confer resistance to both covalent and non-covalent. Interestingly enough, some of the covalent BTK inhibitors do induce the T474I and the L528W as well. And the other thing to note here is that these resistance mutations have really been defined in the relapse setting. We don't have as much information about the resistance mutations in the frontline setting, and so we need to have a lot more follow-up and a lot more patients progress on these drugs to really define how these resistance mutations occur, how often they're occurring, especially as we're using these drugs in the frontline setting as well.
You ever actually order assays to look for these mutations?
So most standard next-generation sequencing available that you have do test for these mutations. So I know that it's available on Foundation testing as well as NeoGenomics. And so if you do order those particular sequencing tests, they do have these mutations available. So let's move forward to the phase 1/2 Bruton study, which was pirtobrutinib for patients with B-cell lymphomas, and specifically we're going to focus down on those patients with CLL. And so you can see here that we dichotomized these patients based off whether they received prior BCL2 inhibitor versus whether or not they did not receive prior BCL2 inhibitor. All patients on this study required prior covalent BTK inhibitor. And one thing to highlight is that in our relapse setting for CLL, in all of the ways that drugs were approved so far, we haven't had a trial that actually looked at the sequence that we usually use for treating patients with CLL. In all of our relapse studies, all of them had received prior chemoimmunotherapy as well. But at least in this particular study, 100% of patients had received prior covalent BTK inhibitor. Other things to highlight is that this was a really high-risk group of patients with CLL, where they had 50% TP53 aberrations, 50% complex karyotype, and 80% IGHV unmutated, which makes sense because this is the relapse setting. Here are our progression-free survival curves, and pirtobrutinib in this phase 1/2 setting led to a median PFS of 18.7 months for all comers. Now, when they specifically looked at those patients who received prior venetoclax, the PFS was 15.9 months. And so it really shows you that when patients get BCL2 inhibitors and BTK inhibitors prior to pirtobrutinib, they do worse. Now, when looking at time to next treatment and overall survival, what's really interesting here is that the overall survival was not reached at the last follow-up, and time to next treatment was 23.2 months. And the reason why I like to highlight this is that although we present progression-free survival in a lot of our CLL studies, when patients progress with CLL, you don't need to change treatment right away. Normally, you can wait a little bit of time before you actually need to change treatment and get the most bang out of your buck for the treatment that you're currently receiving, because the IWCLL criteria for progression have a very low threshold. They're very sensitive. And so normally you can have a little more leg room in deciding what you want to do next for your patients. As you can see here, there's about an 8-month difference between PFS and time to next treatment. Now, in terms of safety, and we've talked a little bit about this already, pirtobrutinib as a single agent looked really good. And so if you look at the AEs of interest, these kind of group the BTKI toxicities, and you can see that the atrial fibrillation risk here is in the single digits. Now, I'll have comparative data to ibrutinib in a second. The bleeding rate is very similar, but the hypertension rate also looks a little bit better on this study also. So moving forward, this is the registrational study that led pirtobrutinib to be approved after prior covalent BTK inhibitor. In this study, pirtobrutinib was compared to investigator's choice, idelalisatuximab or BR. And you can see that the time to next treatment here for patients receiving PFS receiving pirtobrutinib was 29.5 months, and for patients who had treated with venetoclax prior, additionally to the covalent BTK inhibitor, the median PFS was 20 months. Now, one thing that you might ask yourself here is that, does this tell us that we should be going from covalent to non-covalent to venetoclax, given that patients who got prior venetoclax did worse? The answer is it doesn't, because we don't have the information yet on how patients did with venetoclax after they went from covalent to non-covalent. And so until we know that information, it doesn't really speak to sequencing that much, but does highlight that going from either covalent to non-covalent or going from covalent to venetoclax to non-covalent are two very, they're very normal ways to treat patients. Now, this study I thought was super interesting. So this was put together by Dr. Iyer, and what they did was they did a pooled analysis of those patients who actually got the sequence of covalent BTK inhibitor to non-covalent BTK inhibitor, really showing how we normally treat patients. And interestingly here, the median PFS was about the same as what we showed in the previous slides, 19.5 months with pirtobrutinib. However, the time to next treatment was much longer at 32.5 months, which really highlights that when patients have less prior lines of therapy, they do tend to progress slowly, and that leeway to start the next therapy is even longer than what I suggested on the previous slide. Next up is the Bruton CLL 314 study, and this is the study I alluded to earlier. This is a non-inferiority study of pirtobrutinib versus ibrutinib in the relapsed refractory and treatment-naive state. And so here's the overall response data, and it was the same. And so we don't really care about overall response in CLL, but this is how the study was done, and it was found that pirtobrutinib was non-inferior to ibrutinib, which was no surprise. Now, where the surprises started to come into play was when they dichotomized the patients based on whether or not they were relapsed refractory or treatment naive. You can see in the treatment naive cohort that those curves are starting to separate. And you might also look and say, hey, Dr. Kittai, the p-value is less than 0.05. Why aren't we celebrating this as a success that the PFS was better for pirtobrutinib versus ibrutinib? Unfortunately, in the way they studied the study, because overall response rate was the primary endpoint, the threshold to call this statistically significant has not met because the p-value needs to be much lower than standard analyses. But certainly this Kaplan-Meier curve looks great. It does look like the PFS is going to turn out to be better for pirtobrutinib, but we do need to see more follow-up data to see if we can actually state that this was statistically significant. Next up is the safety. And so, as I said earlier, when pirtobrutinib was compared to ibrutinib, the AFib rate looked great at 2.4% any grade versus 13.5% any grade for ibrutinib. The hypertension also looked improved with pirtobrutinib versus ibrutinib, and also the infection rate looked also good. However, the bleeding rate looks about the same. So we're still concerned about bleeding for the non-covalent BTK inhibitors as we are with the covalent BTK inhibitors. Next up is the registrational study that was pirtobrutinib versus BR in treatment-naive CLL, and no surprise here, pirtobrutinib beat bendamustine plus rituximab in terms of PFS, and we'll see if this leads to pirtobrutinib getting a full approval in the front line. However, the majority of these patients were enrolled ex-US, and so we'll see how the FDA views that data. Here's the overall survival, which also looks like it's slightly better for pirtobrutinib as well, and did meet clinical statistically significant as well. There's an ongoing phase 3 study that may change the way that we treat relapsed patients. And here it was pirtobrutinib, venetoclax plus rituximab versus venetoclax plus rituximab. And we actually have a news flash that came out just a few days ago that actually showed that it met its primary endpoint. So it does look like PVR versus beat VR, but I don't really like changing the way I treat based off this kind of announcement. We'll have to see what the data shows, and it's likely to be presented at one of our main conferences coming up soon. This is the data showing that pirtobrutinib does lead to those T474I and L528W mutations, which confer resistance to both the covalent and the noncovalent BTK inhibitors. But this is in the relapse setting, so we'll have to see how this plays out in the front line. But does give us concern when using pirtobrutinib in the front line because we may not be able to use a noncovalent to a covalent, which may affect overall survival. But we'll see how this pans out.
Before you continue real quick to John, any situations right now, putting reimbursement aside, where you want to utilize pirtobrutinib, maybe an older patient with a lot of comorbidities, either alone or also, what are you thinking about the time-limited strategy with pirto and venetoclax?
Yeah, no, I mean, I think obviously these are questions we are going to have to wrestle with as this drug gets these approvals, earlier lines of therapy and in combinations. And I think it's very attractive. Some of the data of the combination data suggests that they may synergize and enhance MRD negativity rates and things along those lines. So I think it's going to be absolutely relevant to us. How do we make those decisions? I think as we start to see this drug move into the frontline setting, I think it will be in older patients initially. We are a little bit still concerned about this mutational profile, rendering other BTK inhibitors less effective. And so I think with time, though, I do see this potentially being a very valuable drug and a drug that we might be using as our go-to in the frontline setting in the next 3 to 5 years.
All right, how about sonrotoclax?
So sonrotoclax is the next generation BCL2 inhibitor. We alluded to this earlier, but it does look like sonrotoclax does lead to superior inhibition compared to venetoclax. Obviously, this is preclinical. This is not in the clinic. Additionally, the sonrotoclax hits a lot of the other BCL2 family members that sometimes confer resistance to venetoclax and has a higher IC50. So there's preclinical evidence that sonrotoclax might be a better drug than venetoclax. And there's 2 clinical trials that have read out in terms of abstracts over the last couple of years. There's sonrotoclax plus zanubrutinib in treatment-naive CLL and sonrotoclax plus obinutuzumab in treatment-naive CLL. In terms of sonro plus zanu, we've had more time with this particular combination, but certainly the data looks great with 100% overall response rate. Additionally, for sonrotoclax plus obinutuzumab in treatment-naive CLL, the overall response rate was 89% with 46% CRs. And so we'll see how this gets developed into the future, but I think the study that we're really most looking forward to is the Celestial study, which directly compares sonrotoclax plus zanubrutinib versus venetoclax plus obinutuzumab. Additionally, there's also a phase 3 study in the relapse setting that's comparing sonrotoclax plus anti-CD20 antibody versus VR. And so that's Celestial relapse refractory CLL. So these 2 studies eventually we'll see, and we'll have more data that directly compares the 2 BCL2 inhibitors. Next up are the degraders. There's 2 simultaneous degraders that are being developed that are pretty much far along at the same point. There's NX5948 and BGB16673. And how a degrader works is that it targets BTK for degradation through the ubiquitin proteasome system. So what's great about this is that it should overcome resistance, regardless of whether or not that resistance is a L528W mutation that confers resistance to the covalent and the noncovalent, because it just needs to bind briefly in order for it to activate its mechanism. And so both of these studies have been done in patients who have relapse refractory disease, and the objective response rates are about 80%, which is classically what we've seen when drugs such as Bruton's tyrosine kinase inhibitors are used in the relapse setting. And the same goes for the BGB16673. So for the sake of time, I'll just skip through these slides. But, the degraders are really nice because we now can conceive of a pathway where we're constantly hitting BTK with well-tolerated medications that allow for our patients to remain on target. And we all know what the toxicities typically are for these medications, so it'll be easier to manage.
So a couple final questions back to John. Actually, someone in the chat room asked this, as Sue Smith also just asked me, your approach in the first-line setting to the patient with del 17p and also unmutated IGVH, John.
Yeah, obviously, I think with the deletion 17p, even unmutated IGHV, I think combinations with BTK, BCL2 combos are really where I'm moving towards. I think the question is, what about continuous therapy for these patients? We've seen survival rates been basically overcome, and I do think deletion 17p patients are a unique population where I do want to consider that. Though I think if they're still very young and getting off of therapy is important, a doublet or frankly a triplet option for those higher risk del-17p patients, based on some of that data, Dr. Kittai, Dr. David's, the AVO data, looks really good, 70% PFS rates at 4 years, and they're having some retreatment data showing that you can then retreat patients should they progress a little bit sooner. So I'm typically approaching those higher risk patients with triplet therapy.
So, final question, John. If you're going to use single agent for del-17p, which one? I can tell you, I know when we ask investigators, they say zanubrutinib because there's more experience with it. How do you make that decision?
Yeah, I mean, I think, zanubrutinib has that unique data set from the Sequoia study, Arm C, which is 110 patients with deletion 17p. It's the largest prospective study being uniformly treated with a monotherapy BTK inhibitor approach, showing really good outcomes for those patients. And so, they have kind of the data to support it, though with that said, acalabrutinib, in the Elevate TN study, which allowed del-17p patients, those patients on monotherapy acalabrutinib also have shown similar outcomes basically for deletion 17p or with those patients without getting monotherapy acala. So honestly, I think any of the drugs you can use, and not one of them is specifically specified for just deletion 17p, and it still comes down to your comfort level using that drug.
All right, thanks so much. We're going to move on now.
Yeah.